All right, Laura, whenever you're ready.
You guys can still hear me okay, right?
Yep, we can hear you and we can see your slides.
Okay, great. So, yeah, thank you all for joining and taking the time out of the day, and Happy New Year. And glad we could get, the series started back up after the holidays. So I will be talking about infiltrative cardiomyopathies today. There was a request for the topic, so hopefully you guys get something out of it. So just the objectives for the talk. We're just going to review the subtypes of the various cardiomyopathies, specifically defining infiltrative cardiomyopathies, and then we're going to review the pathogenesis, diagnostics, and management of the two more common infiltrative cardiomyopathies that we see on our floor, amyloidosis and sarcoidosis. So when you have a patient that has cardiomyopathy or heart failure, it's good to understand what the cause of the heart failure is. And it can be divided into two categories: ischemic, which is pretty obvious, patients who have had either MIs or some other, decreased myocardial perfusion, or non-ischemic. And then there's a whole host of these non-ischemic cardiomyopathies. And just to review, infiltrative, which we'll speak a little bit more about, viral, familial, valvular, arrhythmia-induced, peripartum, the stress-induced, post-surgical, acute PE or LVOT obstruction. And then when you have the various heart failure diagnosis, it's good to kind of know the physiology of the disease process. So for our infiltrative patients, it's more of a restrictive physiology. As you can kind of see in the picture there, you have thickened ventricles, it's stiff, and they don't stretch or fill well. So just a definition of infiltrative cardiomyopathy: it's really characterized by an abnormal deposition or accumulation of the substance in the heart muscle. We'll go through the different types, but there are similarities and overlaps in both the echo findings, the cardiovascular presentations, but there is a broad range of extracardiac manifestations. These disease processes can affect multiple organ systems. Obviously, we're going to focus mostly on the heart here. And they do oftentimes come from a genetic mechanism, but they could be environmental, like inflammatory, or idiopathic. Also, if anyone has questions, please feel free to stop me. I can't really see a chat, so just someone let me know. So our infiltrative cardiomyopathies, cardiac or amyloidosis, there's two main types that we see that affect the heart. We have our immunoglobulin light chain, or otherwise they're sometimes known as AL amyloidosis. And we have our transthyretin, sometimes known as ATTR amyloidosis. Sarcoidosis is kind of a class in and of itself. And then it's just worth mentioning that there's this other category of the genetic infiltrative cardiomyopathies. Some of these we've seen, others I've honestly never seen, but the more common are the first three: the hemochromatosis, the iron overload and iron deposition, Fabry disease, and Danon disease. But we're not really going to speak on those. We're going to focus on the amyloidosis and sarcoid. So to start, we're going to start with our amyloidosis, and it is a disease of misfolded proteins. So you can see here you have a normal protein, they get misfolded, and then they develop these amyloid fibrils, and that's what deposits into the various organs and the heart muscle. So kind of reiterating, it's a disease caused by deposition of the misfolded fibrillary proteins in the extracellular space, and you can they can be found in the GI tract, the liver, kidneys, the CNS system. So various organ systems are involved. There's more than 30 precursor proteins that can undergo these molecular transformation that result in the amyloid fibrils. The two main types, again, that we see affecting the heart muscle are the immunoglobulin light chain, or AL, and the transthyretin, or TTR. There's also some additional less common forms of amyloidosis, AA, which is kind of a autoimmune or inflammatory syndrome, and then also dialysis related. We're not going to focus on those today. Again, they can affect any organ. They don't always affect the heart, But when the heart is involved, these patients, typically have a high morbidity and mortality. So it's important to recognize and treat sooner rather than later. So for how the heart is affected by this infiltrative process, it really, it leads to biventricular wall thickening and concentric remodeling, again, that restrictive physiology. You can have atrial dilation. It can affect the myocardial blood vessels, which can cause cardiac ischemia, and it can cause conduction system disturbances. So I'm sure you guys have seen a lot of patients with amyloidosis have a fib, a flutter, a tach, or other AV conduction abnormalities. It's mostly atrial arrhythmias that at least I've seen with the patients with the amyloidosis. So kind of to further go into the two main types that we see, the AL, light chain amyloidosis, is a disease of the bone marrow, and it results in a plasma cell dyscrasia. This is the more rare type, only about 2,500 cases in the US per year. It's similar to like a myeloma or a MGUS or something along those lines. And it's important to think of this one as the cancer type of amyloid, and that will help you understand the treatment. And these patients have the monoclonal immunoglobulins. They have the free light chains in the serum or the urine protein electrophoresis, which we send off often. We'll talk a little bit more about that, but that is good for diagnosing and monitoring treatment response. On the flip side, we have our ATTR transthyretin amyloidosis, and that comes from a liver-derived protein. That is the more common amyloidosis that we see. And that can further be subdivided into either a genetic form or a wild type. The wild type typically presents later in life after age 70, but the genetic can show up anytime, like middle age. African Americans seem to have it a little bit more commonly, but the transthyretin amyloidosis is the more common form that we see. All right, so the clinical manifestations. So it's good, if you're chatting with your patient and they mention any of these kind of symptoms, it may lead you to think that they have amyloid, because, we do see a lot of patients that have a new diagnosis of a cardiomyopathy or, a non-ischemic cardiomyopathy that hasn't been, figured out what exactly the type is. So obviously they have something wrong with their heart. Typically they'll have protein in their urine. They may report carpal tunnel syndrome, or that they've had like a carpal tunnel release surgery in the past. Oftentimes these patients have low blood pressure, specifically orthostatic hypotension, so when changing position. They may have peripheral neuropathy, spinal stenosis, GI abnormalities, eye manifestations such as floaters. They can have erectile or urinary dysfunction, macroglossia, which is an enlarged tongue, a ruptured bicep tendon, and thyroid abnormalities. So sometimes, someone might show up with this ruptured bicep tendon, no other history, and then ultimately leave with a diagnosis of amyloidosis. So just a couple pictures here. On the left is the macroglossia, and I have seen patients on our floor with tongues that look like that, whereas I really haven't seen a patient present with a ruptured bicep tendon, but that is what you would see. So the diagnostics for amyloidosis, obviously all of our patients have EKGs. What you might see on an EKG is low voltage, a poor R wave progression, this pathologic Q wave, the atrial arrhythmias, various bundle branch blocks, or QT prolongation. Blood work might reveal low level troponin, low level, or not even necessarily low level, but they could have an elevated NT-proBNP. Our patients oftentimes undergo cardiac MRI, especially as we're trying to figure out, the cause of their non-ischemic cardiomyopathy. And what you might see for a patient with amyloid is this diffuse subendocardial or transmural LGE, or late gadolinium enhancement. So patients, that's kind of a marker of inflammation or infiltration. And then the various patterns of LGE kind of help point to a diagnosis. The light chains, as mentioned, which is like the kappa and the lambda. And then we send off the serum protein electrophoresis and the urine protein electrophoresis. And that again helps with diagnosis. This is for the light chain or the cancer type amyloid. And it also helps with treatment response. So as they're undergoing treatment, the oncologist will trend these levels and kind of hopefully see that they're going down. We'll talk a little bit about the echo findings. For AL amyloid, you really need a tissue diagnosis. Endomyocardial biopsy, if it stains for Congo red or it has amyloid fibrils seen on the electron microscopy, that's diagnostic. But oftentimes we can just get a fat pad biopsy for these patients. So that's when the FNA team will come to the bedside. They'll just take a little sample of the from the stomach, and then they can stain it for Congo red. And if that's positive, that's diagnostic for the AL amyloid. And then you may need a bone marrow biopsy as well. So you may have one or multiple biopsy sites, and some of this will come from the oncology team when they're, deciding what treatment or if they have enough information to have a diagnosis and a plan. The PYP scan, that's diagnostic for the TTR amyloid. And then if the patient does have TTR, we do typically send off for gene sequencing. Sometimes we do that as an inpatient, but oftentimes that's done as an outpatient. So just to kind of point out some echocardiographic findings, the pictures here, hopefully you guys can see them okay, but on the left, these are both the same view. It's a parasternal long axis of an echocardiogram, and nicely it's labeled here. On this side here, I'm not sure, can you guys see my mouse or no?
Yeah, we can see it.
Okay,
Yes.
so this is the normal heart. So obviously you have the left atrium, the left ventricle, the aorta, the right ventricle. This is all normal here. So this is a echo, a parasternal long axis of a patient that has amyloid. So what you can see here is they're really like thickened ventricular walls. The black is blood. So you can kind of see here that the LV chamber where the blood is filling is very small. And then also the enlarged left atrium. So if you see a parasternal long axis that has this really thickened ventricles, that might lead you to suspect amyloidosis. Hypertrophic cardiomyopathy can kind of look similar, but it should at least alert you that something is not right. And when we get echoes for patients that either have or we suspect amyloid, we often want to get strain imaging, and that's when the patient kind of bears down. And what we see that's diagnostic for amyloid is that the apex is spared. So that may be reported as like a cherry on top pattern or a bullseye pattern. So for the treatment options for patients with amyloid, again, AL amyloid is the cancer type of amyloid. So that treatment is chemotherapy or stem cell transplant. And these patients are often referred to oncology, and then they're treated in collaboration with a cardiologist that specializes in amyloidosis. Like for us, it's Dr. Peretti and her team, and then Dr. Drockman over at Presby treats a lot of these amyloid patients. Unfortunately, it's often diagnosed at a later stage, and it really has high mortality, 35 to 40% at the first year after diagnosis. On the other hand, our patients that have the TTR amyloid, as people are recognizing this more, I think it's being diagnosed a little bit more frequently, and there are treatment options that help stabilize the transthyretin and then generally slow the progression of the disease. So the first treatment here, just worth mentioning, this difluzinol, which I've never seen used, probably because it has this NSAID property, and as you hopefully know, we avoid NSAIDs for patients that have heart failure. So the more common med that we see is tafamidis, and really the ultimate goal of the drug therapy is to slow the progression of the disease. Previously, we've used a lot of doxycycline, but a randomized control trial in 2021 really failed to just prove that it had a significant benefit. So we don't use doxy as much as we used to. And then when you're treating your patients, it's important to know that amyloid fibrils bind to digoxin. So, you know, we don't use a ton of digoxin, but obviously we're a cardiac floor, so it's out there. Patients with amyloid are really prone to dig toxicity. So it could be used cautiously, but oftentimes we avoid digoxin. So some other considerations for patients with amyloid, they're really poorly tolerant for our standard heart failure therapies, our guideline-directed medical therapies, our beta blockers, neurohormonal blockade, our vasodilators, and that's really with the restrictive physiology of the disease. So they oftentimes have the low blood pressure, the orthostasis. So a lot of times it's really just supportive care with compression stockings or midodrine that we can use to hopefully mitigate the orthostasis. With their atrial arrhythmias, I don't know if you've ever had a patient with amyloid. A lot of them do have AFib. And most of the time, if they have AFib, we can just leave them in it. But sometimes we do try to cardiovert. If the patient is going for a cardioversion and they have amyloidosis, no matter if they've been compliant with their anticoagulation without interruption, we always get a TEE because they are really prone to developing clots. So some of our other patients, if you know, we know that they've taken their anticoagulation religiously, like we can just do a cardioversion without a TEE. But for this patient population, despite their anticoagulation status, we would definitely get a TEE prior to cardioversion. Transplant's an option, but just a couple considerations for the patients with AL amyloid. If they are transplanted and can get to transplant, oftentimes they need a stem cell transplant post-transplant or chemotherapy once they recover to kind of, because they still have the amyloid in their system, and obviously you want to prevent it from affecting their new heart. Patients with the genetic TTR form are often referred for heart-liver transplant, and that again is because the transthyretin is a liver-derived protein. So if you're going to transplant the heart, you would want to remove the liver and the source of the abnormal proteins as you're doing the transplant. Patients with amyloid are typically considered for an LVAD, and that's because they have the small left ventricular cavity, that restrictive physiology, and then they have comorbidities and other organ involvement that would just really raise their morbidity and mortality, and they might not get the benefit from an LVAD that, you know, we would like to see. Obviously, it's a big surgery to put them through it and then not do well is not what we want. So that's kind of the quick and dirty and a lot of information about amyloidosis. We'll talk about sarcoidosis, and then if you guys have any questions, you know, feel free to reach out. So sarcoidosis is a disease of these granulomas, and that's the infiltrative substance in this disease process. And here's a little slide that kind of depicts what a granuloma looks like. It's a rare disease. It can be multi-system, and really the etiology is unknown. It's characterized by the presence of these non-caseating granulomas that are deposited in the various organs. Granulomas are like tiny collections of inflammatory cells that form when your immune system tries to fight off harmful substances. And it could be either an infection that you had, a chemical exposure that you had, it could be environmental, or it could even be against your own body's proteins. Sarcoid is most commonly found in the lungs and the lymph nodes, but it can affect the heart and other organ systems. Again, the cause is largely unknown, but it's thought that it's really the body's immune response. And it can be genetic or environmental, as mentioned. So this is like reiteration here, but it's multi-system. And the signs and symptoms really will depend on what organ system is involved. A patient may present initially with vague symptoms, like as mentioned here, fatigue, swollen lymph nodes, weight loss, or painful swollen joints, which obviously could be anything. But they may also have these pulmonary complaints. They may have a persistent dry cough, shortness of breath, wheezing, which hopefully would prompt a provider to get a chest x-ray that might show some abnormalities and lead to further testing. The cardiac symptoms for patients with sarcoid, they may have chest pain, they may have shortness of breath, syncope. They could even, unfortunately, present with like sudden cardiac death if, they didn't know they had sarcoidosis. They could have irregular heartbeat or a sensation of palpitations and edema. Some skin findings for patients. They can have rashes, sores, discoloration, and sarcoid is a disease process that's well known to infiltrate the eyes as well. So they may report blurry vision, eye pain, the dry eyes, redness, sensitivity to light. So again, it really depends what organ systems are involved. So there may be some overlap, like if your patient has, they don't have to have the skin findings, but they could. Like, this is just the broad range of what you might see for patients that have sarcoidosis. So it's an overproduction of these granulomas, and they can build up, and now we're speaking mostly of cardiac sarcoid, but build up in the heart. And what happens when these granulomas build up in the heart is that it can disrupt myocardial blood flow, it can cause heart rhythm abnormalities, and lead to heart failure. So if they affect the blood vessels, obviously, that's reduced myocardial perfusion, and that can lead to like similar syndrome to like a heart attack or myocardial infarction. And if they infiltrate the heart muscle, that leads more to the heart failure syndrome. And it can also specifically affect the cardiac valves. What you may see with patients that have cardiac sarcoidosis are arrhythmias. Oftentimes, it's high PVC burden and often multifocal. So that's what you might see on telemetry, other conduction abnormalities, and obviously heart failure. So the diagnostics for sarcoid, again, if your patient presents with the vague symptoms but has any type of pulmonary complaint, hopefully they'll get a chest x-ray and then a CT scan of their chest, and they may see some abnormalities in the lung tissue or these enlarged mediastinal or hilar lymph nodes, which is helpful because that could be a site of biopsy to prove diagnosis. They would probably get PFTs, and what you would see on your PFTs for a patient that had sarcoidosis is a restrictive pattern. You may have a reduced diffusing capacity. On your echo, the earlier stages of sarcoidosis, you may have focal areas of edema or increased wall thickness, but if it's late, you might have, focal akinesis or dyskinesis, wall motion abnormalities, wall thinning, or even aneurysms. PET scan. So we send a lot of our patients with sarcoid for the PET sarcoid scan, and that really helps determine if there's active inflammation and helps guide therapy. These patients would undergo a cardiac MRI for diagnostics, and again, they would have the late gadolinium enhancement and various patterns that suggest sarcoid. We might check an ACE level. That's not specific for sarcoid, but it can aid in diagnosis. So there's other diseases that cause elevated ACE levels, but it's helpful. This Veeam test, which I don't even know if I'm pronouncing that correctly, we don't use it at Penn. It's really rarely used, but it's a skin test, interestingly, where a patient where you suspect sarcoid gets a little injection of a sample of a spleen of a patient that has known sarcoid, and then in 4 to 6 weeks, you see if there's granulomas that form. I don't even know if we use it at all in the US, but it's been out there previously. And then patients that have sarcoid should get an eye exam just because of the chance for ocular involvement. So here is just, a little picture of a PET scan. Like I said, we send a lot of our patients for the PET scan. So just to kind of give you an idea of what it might look like if it's positive, you can either see like a diffuse area or diffuse lighting up. That means, obviously you have a lot of active sarcoid, or you could just have patchy areas of inflammation. And down here in the bottom right corner, you can see like that's the poor prep, the patient that didn't follow the low carbohydrate diet. So it's kind of hard to interpret those results.
Hey, Laura, we have a question.
Yeah.
What is an ACE level? Like, what is that checking?
Well, I mean, I would say it's just checking your ACE level, but I think it's an inflammatory type marker, but it may be checked in other type of like autoimmune diseases, like rheumatologic diseases. So it may be positive for other processes, and I think it's mostly like the autoimmune inflammatory type syndromes. It's just sort of helpful to put the whole picture together.
Got it. Thanks.
Mm-hmm. So again, there's not like a specific like diagnostic like single test, but what you would do is like you get your history and physical. So you have clinical and radiographic findings that might suggest sarcoidosis. You want to exclude other disease processes that present similarly, and then hopefully you would have a biopsy that shows a granuloma. So our patients with a mediastinal lymphadenopathy could get a bronchoscopy with sampling of those lymph nodes. And if you have the granulomas, that's diagnostic of sarcoidosis. You can biopsy the heart, but as it can be sort of a patchy infiltration in the heart muscle. So depending where you biopsy, you may get, a false negative result. So again, you kind of have to take everything into consideration and put the whole picture together. So for management, some patients could be totally asymptomatic or go into remission, and therefore they don't require treatment. But for patients that are more symptomatic, treatment is immunosuppression, first line being steroids, and then depending like how active the disease process is, and this comes oftentimes from that PET scan, you may add additional immunosuppressive agents such as methotrexate or MMF, and then even further monoclonals or, consideration for advanced therapies. So these patients do typically tolerate the guideline-directed medical therapy decently. So we oftentimes use those. Again, a lot of them have the ventricular arrhythmias, so they have to have antiarrhythmics, ICD for prevention of sudden cardiac death. They may be referred for advanced therapies. And these patients too, we would oftentimes choose a heart transplant over an LVAD, and that's because sarcoid can infiltrate the right side of the heart as well. And I'm sure you guys know the left ventricular cystovites really only support the left ventricle. So if you have a right ventricle that's really affected by sarcoid, over time, you're gonna really succumb to right ventricular failure. We can use inotropes in these patients, but we usually are very cautious, and that's because of how arrhythmogenic sarcoid can be. So, we can use milrinone at obviously the lowest dose possible, continuous telemetry, monitoring them in the hospital. But, we have to be really careful. And it is important to know, or just something to consider, that if these patients do undergo heart transplant, they could have sarcoid recur post-transplant, but that's really less likely when they're maintained on the immunosuppression and the corticosteroids. So that is the main meat and potatoes of the talk, but hopefully you guys just kind of get out of this that like not all cardiomyopathies present the same way, and they're not treated the same way. So that's why it's important to know, really what disease process is leading to heart failure in your patient, and then how to manage it. So I hope you guys have a better understanding of the cardiac amyloidosis and the cardiac sarcoidosis, and I'm happy to take any questions.
I've been unmuted if anyone wants to ask.
That was really good. Thank you.
Oh, you're welcome.